Hi friends, let's try to solve this question. Which of the following types of thyroid cancer is associated with increased in the level of serum calcitonin? The choices are papillary cancer, follicular cancer, anaplastic cancer, and medullary cancer. This question, what is calcitonin? Calcitonin is basically a polypeptide which is secreted by the parafollicular cells or C cells of thyroid gland, which is present usually located superolaterally on each thyroid lobe. So among these choices, which of the following types of the cancer will be are associated with parafollicular cells will be the answer. So as we know, there are different types of the thyroid cancer. In the common being, those arising from the follicular cells are papillary cancer, follicular cancer, and the third type is anaplastic cancer, which is non-differentiated, and there is a fourth type that is arising from the parafollicular cells, that is the medullary cancer of the thyroid. So it will obviously be the medullary cancer of the thyroid which is arising from the parafollicular cells, which it can be associated with the increased level of calcitonin. Medullary thyroid cancer is found in up to 6% of the thyroid cancer. The most 80% of the times this medullary cancer of the thyroid will be sporadic type, while 20% is associated with is inherited as autodominant disorder and usually associated with some syndromes like MEN type 2A, MEN type 2B, or familial medullary thyroid cancer. In those patients who are having sporadic type of presentation, usually the patient presents as a mass lesion in the thyroid. So usually in one of the lobes there will be a mass that can be confirmed with the help of an FNAC, or the patient may also have sometimes, rarely, patient may present only with increase in the serum level of calcitonin. If we come across a patient who is having a mass as well as increased level of serum calcitonin, we can be 100% sure that this is basically a medullary cancer of the thyroid. Sometimes in advanced stages, the patient may present with diarrhea and flushing like symptoms. In about 20 to 25% of the patients, the medullary thyroid cancer will be a part of the syndrome. So in these patients, patient may present as medullary thyroid cancer, or the patient may present with other diseases of this syndrome, like the patient may present with episodic hypertension associated with severe headache, which is suggestive of pheochromocytoma, or the patient may present with hypercalcemia, which is because of the hyperparathyroidism, again because of this syndromes. So how we are going to investigate this patient? Usually we can diagnose the patient to be having medullary thyroid cancer easily with the help of an FNAB or FNAC, which will show amyloid stroma. As well as in the blood, we will find there is increased level of the calcitonin, and we can also come across increased level of carcinoembryonic antigen in the blood. This may suggest the diagnosis of medullary cancer thyroid. So coming to the management of medullary thyroid cancer, there can be two settings. One, we already know the diagnosis, that is preoperatively already diagnosed with the help of an FNAC. We already know that the patient is having medullary thyroid cancer. So in these patients, when we go for a planned surgery, the ideal surgery is we should go for a total thyroidectomy. Now this medullary thyroid cancer also goes to the lymph node, usually in the central compartment, that is near the thyroid gland. So ideally we should go for total thyroidectomy with prophylactic, that is whether lymph nodes are enlarged or not enlarged. Prophylactic central lymph node dissection should be done, that is level 6 lymph node dissection should be done in all the patients. While if the lateral lymph nodes are enlarged preoperatively, if we know by ultrasound or by clinical examination that their lymph nodes are enlarged, then we should go for lateral lymph node dissection also. Now in those patients where in the post-operative settings we come to know that the patient is having medullary thyroid cancer, that is if we do a lobectomy and we come to know that the patient was having medullary thyroid cancer, in those patients completion thyroidectomy with prophylactic central lymph node dissection should be done. In those patients which are associated with syndromes like MEN type 2A, MEN type 2B, we should go for prophylactic thyroidectomy. That is, in MEN type 2A, total thyroidectomy should ideally be done before the age of 5 years. And in MEN type 2B, the ideally total thyroidectomy should be done before the age of 1 year. Now, as these medullary thyroid cancer, these are not arising from the follicular cells. So there is no role of radioactive iodine therapy or thyroid stimulating hormone suppression. These does not carry any role in the management of the medullary thyroid cancer. So prognosis wise, medullary thyroid cancer is considered to be a bad prognostic disease, with the worst prognosis seen in MEN type 2B, then a better prognosis with sporadic, and best prognosis is as seen with MEN type 2A of medullary thyroid cancer.